Yeah, sorry about that. Away we go. Now we're ready to go. So I just wanted to start with a little bit of what is the core problem that I think we're confronting, whether it's at Mayo or someplace else. And it's this balance between three things of providing service that may have some attributes or adjectives associated with it: predictable, repeatable, safe, quality. You might add other kinds of attributes. I certainly would want to add affordable, accessible, those kinds of things. The second dimension of the problem is, how do we provide joy in practice to clinicians, and a sense amongst clinicians that they actually are able to do what they want to do as they treat patients and help them find health. And then the last, of course, is to meet financial goals. And there's a natural tension between all three points of this triangle as we try to do all three simultaneously. And I don't think it matters what kind of organization you're talking about. This is a fairly generic kind of construct, but I think it's helpful to describe what we face in healthcare. And then because it's 4 o'clock in the afternoon and I understand the room there is warm, I thought some math would be really welcome as a way to liven up the crowd. But these are some of the immutable laws of waiting around. And those of you who might remember your introductory operations research classes might remember this. The thing at the upper left is Little's Law, and it just describes how many people are standing around in line, depends on how many people are coming into that line, and how long does it take for them to wait in line and then be served. And the little graph on the bottom is, if an activity takes 1 minute to do, and the utilization of the capacity to do that service is 0. You're the first person to walk up to an ice cream stand, and it takes them 1 minute to make you a cone. Well, guess what? You're going to walk up and walk away in 1 minute. But if the capacity of ice cream servers is about 50% used, well, it's going to take you about 2 minutes to get your ice cream cone filled. And when you get to something close to 90% utilization, it's going to take you 10 minutes to get your ice cream cone filled. And those of you who are able to endure introductory operations research and get to the second and third level classes will remember there's lots of more sophisticated models than this that deal with the number of servers and the type of service and how do people queue up and how do they arrive and all those kinds of things. But really, the details aside, it's all the same thing. How long people have to wait for service is fundamentally determined by the characteristics by which people enter the system and the rate at which they're served. And so in all of our organizations, when we have frustration amongst our patient customers about wait time, it really comes down to some kind of variation of this problem. What I'd also say is that the physician and the person responsible for patient experience really wants that capacity utilization to be off to the left, to be pretty small. Maybe the people who are responsible for financial performance want it to be higher. And sometimes we end up on a slippery slope where the goal becomes, how do we make sure that every single minute of a billable clinician's time is used? And that's not just a slope, it's a slippery slope to hell, because if you make a physician completely scheduled 100% from morning to night, you can accurately predict what is going to happen, and that is you are going to have patients who are waiting for much longer than their service would require. So, hopefully this resonates with folks. We have this challenge in a service delivery organization where demand cannot be predicted, where patients are not widgets on an assembly line. We have to balance these different kinds of characteristics. So what's the context at Mayo? And, Mayo isn't like every place, and every place isn't like Mayo, but, maybe there's some things that are useful here. Our principal value that guides everything we do is this notion of the needs of the patient come first. It was a phrase that was included in a lecture given by one of our founding physicians in 1915, and it continues to resonate. And if you ask the head of surgery or the person who's responsible for cleaning up the room what Mayo's principal value is, everyone will say without prompting, we're here to meet the needs of the patient first. And how is that reflected in the way we're organized? And there's some similarities here a little bit to the VA context. We are an integrated group practice in which the goal is to be able to bring physicians of different backgrounds and specialties together to provide a coherent and integrated whole person approach to care. We like to say that we are the first and largest integrated group practice in the U.S. Our physicians are salaried, and this phrase, offering neither personal benefit nor penalty for decision-making, is a really big deal. We don't pay our physicians based on RVUs or what they do or what they don't do. I can tell you from recent personal experience, I needed to have some surgery, and it wasn't clear whether we needed to have one surgical team or two surgical teams. Well, it turned out that we only needed one, and the second went home. Well, it didn't make any difference to that second surgical team. They were paid whether they did surgery on me or not. And that sort of thing infects the way we think about care, both the clinicians and those of us who are non-clinicians. And then finally, there's this idea of an unhurried exam. At least at initial intake, we have built into our system a real primacy around the idea that it takes time to hear what a patient is confronting. And a lot of the patients that come to Mayo as a destination medical center maybe haven't gotten a good answer someplace else, or they've gotten a very dire diagnosis, and they would like to come to Mayo because they think that they can get a really great answer there from a top-notch medical center. This is a kind of identity that many academic medical centers hold. So the other context for our scheduling are the two last pieces here. We're primarily a destination medical center. Many of our patients come from a short, car drive away from our facilities in Minnesota, Arizona, and Florida, but a lot of them don't. A lot of them travel hundreds or thousands of miles, and it's a problem for people to be away from home for an extended period of time. And the goal is to get to the end of their treatment and return them home. Well, it turns out that's not just of value to the patient who flies 2,000 miles to come to Mayo Clinic. It's just as valid for someone who comes from Belle Plaine, Minnesota, and has a 30-minute drive home from Rochester. Those patients also would like to get in and out. It's not helpful to wait around, waiting for some service, having to wait another day to get a lab or another 2 days to get an imaging study. And it's not nice to be in a hospital. Anyone who spent any time in a hospital knows you want to get in, you want to get out. And finally, we're also a research and education center. And in some ways, this has a lot of parallels to the VA, too. The VA does a ton of teaching, and of course it does research. And the clinicians who work at the VA also need to balance their time amongst teaching and some research activities in addition to patient care. That's kind of our background and our context for how we approach those particular irreducible problems and the immutable laws of waiting around. So here's our scheduling principle with a little bit more detail. So what we try to do and what we actually do is we optimize to the patient itinerary. So if you think back to that math problem that I put up earlier, you can optimize around a couple of things, one of which is keep your servers busy, and the other is get people through efficiently. And it's been our conscious decision to optimize towards patient itinerary completion. And our goal is to get every patient through our system in 5 to 7 days. And this is something that we put on our benchmark, and we report it to our board of trustees. It's included in the performance reports to each of our clinical departments and so on. And we achieve most of the time 90% effectiveness. And that 5 to 7 days might include someone who arrives at Mayo, who has a series of imaging and lab studies, might have assessment by multiple specialties and multiple clinicians, that might lead to a diagnosis, that might lead to a surgical procedure. It might even lead to an inpatient event, and it leads to a discharge. We're seeking to get all of those visits accomplished within a 5 to 7 day period of time. So there's lots of ways that we then manage the scheduling mechanics to support that. And by scheduling mechanics, I mean not the patient schedule, but the capacity and the clinician scheduling. What do we need to do to be ready to get any patient through in 5 to 7 days? And oh, by the way, still meet our financial goals, which in our case is to produce a net operating income, which we use to expand our services and to fund research and education. And the way we do that is managing capacity. The metric that we use is staff on the floor, which is both our inpatient and outpatient physicians. Many of our physicians serve in both an inpatient and an outpatient role. And so knowing what people are on the floor and what particular service lines are they attached to that day is a key to understanding what our capacity is so we can hit the itinerary goal. We also have well laid out calendar times for both staff and visit types. So we might understand that pick a chest radiologist, for example, might be assigned to doing x-rays. They might be assigned to doing MRI or CT scans. They might be assigned to look at outside materials that have been referred to us by someplace else, which we are then rereading for the benefit of our clinicians, so we get a second read beyond the image that was done someplace else, that kind of thing. And then visit type obviously is divided into the kinds of things you'd be familiar with, an initial visit, an ongoing visit, and so on. Then we do lots of planning and load and capacity balancing between specialties and within specialties so that we understand how the flow works from group to group to group. And it turns out that different kinds of departments need different levels of actual staff on the roster in order to meet different staff on floor metrics. And that has to do with the amount of research done with the department. It has to do with the intensity and characteristic of the cases that those particular physicians see, and so on. And then I'd also say one of the things that we built into our system is the ability to have a flexible itinerary, which means when a patient arrives, they have an initial set of visits, which we develop by a set of guidelines, and I'll talk about those in a minute. But we also want to have the ability to call an audible, that a particular clinician may have a visit with a patient, review some outside materials, have some dialogue with a patient, and then make a decision that they would like to have a particular imaging or lab study done, or they might want to have some sort of procedure done. And we want to have the ability to offer that service to that patient in real time. What we don't want to do is, thank you, Mrs. Jones. We know that you came from 1,000 miles away, but so sorry, we can't get you in to see this specialist until next Tuesday. That won't be a problem. We'll just fly home and come back again. That's a terrible answer, and we never want to do that. So we want to have the ability to offer a flexible itinerary. So here's some of our scheduling mechanics. In the early days of Mayo Clinic, it was the preferences and plans of the individual physicians and specialties. They would have a particular routine on how they like to do things. So someone presents, and we believe that they might have a gallbladder problem, for example. The particular physician might have a program by which they typically go to assess that gallbladder problem, which then leads to some sort of either medical or surgical response. But over time, as we got more sophisticated and added more specialties and subspecialties, there was a lot of focus on doing scheduling within specialties, and then in its latest mode, doing scheduling across specialties. We simply weren't able to meet the patient demand for having a good, strong itinerary if we couldn't manage across all specialties. And that gets to be really complicated. And it was expressed in a whole bunch of sort of one-on-one or 1 to 2 kind of measures between frequently connected departments. But even that fell apart. You couldn't just have oncology and surgery manage their schedules together. You needed to include everybody else, radiation oncology over time, other kinds of specialties, for example, in treatment of cancer. So that led to a whole set of decision trees that described what was needed for a particular patient to have a particular problem addressed. And I can talk more about the depth and content of those decision trees, but they would describe a particular diagnostic type based on what we understand of the patient as they present themselves or as a referring physician presents them. We then built those decision trees into a proprietary Mayo scheduling system. It was basically a very large integer programming piece of software that would allow us to manage a schedule prospectively for a day, a week, and then even further out than that so we could manage demand. Then, of course, we had a big project from 2015 through the end of 2018 in which we converted our 3 large destination centers plus our community care system from 3 different EHRs to a single instance of an EHR. We happened to use Epic. And the Epic software as available to us in 2015 didn't have the ability to manage these kinds of decision trees. So we took all of the logic of our Mayo scheduling system in our relationship with Epic, gave them that IP, and Cadence was extended. Cadence is their scheduling software. Cadence was extended to have this ability of loading decision trees. Now, they had something like this. It was pretty close, but we had hundreds of thousands of nested decision trees, which we managed on a real-time basis, and that just wasn't available. Well, it was available in the 2017 version of Epic, which we used to launch into our hospitals and clinics. And so, essentially, most of what Mayo does from a software and logic perspective is available to any customer today. Any Epic customer today, should they decide they want to build decision trees at the level of depth and complexity that we do. So what are the next challenges confronting this? It seems like, maybe it works okay. We're hitting our goal 90% of the time. Well, the challenge is going to be at least these 3 things. Pressure on reimbursement says the unhurried exam is going to be a challenge. It also means that our utilization of clinicians needs to increase. We don't share what our utilization rates are, but they're certainly not 90%, and it certainly doesn't lead to people waiting around unreasonable amounts of time. But we're going to need to find ways to act more efficiently because we're not going to be paid as much for each unit of physician time. We also have increasingly sophisticated and complex integration as care gets increasingly complex and sophisticated as new therapies come online, but also as our integration at the kind of levels that Joe talked about arise, which is integration with other kinds of organizations. We want to receive a patient from the patient's medical home. They're getting great care at home. They're just coming to Mayo for a particular portion of their care, and we need to return them home, and we need to find ways to, in graceful ways, integrate with the kinds of processes and methods that those other health systems are using. It's no good for a patient, to have a good experience at home and a good experience at Mayo, but a terrible experience transitioning between the 2. And then finally, there's consumer expectations are changing. The millennial generation says, I don't want to get on the phone and talk to anybody. I want to get online and I want to schedule my own appointment and I want to decide what services I need. Well, in some ways, that's a little bit difficult. Scheduling a reservation at a restaurant on Open Table is a little different than scheduling yourself a heart surgery. But there's ways on the edges in which these expectations are real. And if we don't meet them, consumers will go to the organizations who do meet them. So I'm going to come to the end here on this last slide, is to just talk a little bit about interoperability vis-a-vis scheduling. And I know we have people on the panel today who are terrific experts in interoperability, and I'm looking forward to hearing from them. But I want to just talk about the nexus between the 2. So as a destination medical center, when we think about scheduling, interoperability is also integral to that. We need to have the ability to receive outside material. And until recently, that job was paper-based. We still have a significant number of patients who come to Mayo Clinic lugging boxes of medical records, paper medical records. It's getting better and better all the time. We have been pleased with the interoperability on two levels. One, between different Epic systems through Care Everywhere works very nicely. Our ability to send and receive direct messages to other systems that participate in directed exchange has been really important, but we're not there yet. We also need to return the patient home and send instructions to them in a reasonable way, and we do that in a variety of ways, and we can talk more about it, but it's a mix of a patient app, it's a mix of printed materials for patients who like printed materials, and it's also communication back to the patient's medical home physician, both in the form of medical records which we can exchange through Care Everywhere or directed exchange, but also in the form of a letter from the physician at Mayo back to the referring patient. And it's been a big hallmark of Mayo that we take the time, that clinicians take the time to dictate these long, thoughtful letters that describes the course of care. We also need to have the ability to coordinate care. For example, someone might come to us for an oncology assessment. They might return home to receive their chemotherapy. Maybe they want to return to Mayo Clinic for their surgery. We need to find a way to coordinate that care across multiple organizations. And then last but not least, as a destination medical center and academic medical center, we want to have the abilities and opportunities to provide virtual care. We do a fair amount of work today in virtual ICU and telestroke. There's other things that we are increasingly doing and have ambitions to do in the future. And then what I would also say, maybe as a way of being deliberately provocative, is that HL7 Fire is where the action is in terms of interoperability in the future. If it weren't already being adopted by Apple, Google, Microsoft, and others, the fact that it is embedded in the draft regulations from ONC say that FHIR is where we're going to go in terms of creating modern interfaces between organizations. And it's the kind of thing that we dreamed of, those of us who worked on health IT standards through the 2000s. We were hoping for this, and we got there. But I would also say it's highly necessary, but not completely sufficient. A technical interface means nothing if there isn't the business processes and other kinds of processes that take into use these technical capabilities in order to provide something that's patient-centric and aimed at better health. And then where I'd like to really close is this idea that something like HL7 Fire may in fact be a type of revolutionary wedge of the type we've seen before in other industries. I cannot think of a single industry that moved from paper to digital and then connected those digital hubs together in e-commerce kinds of ways. Every single industry that's gone through that change has been completely disrupted. And we are fooling ourselves if we think that we won't be completely disrupted internally as we adopt these interoperability standards which allow us to act differently. Frankly, I'm looking forward to the disruption. There are so many things we do in healthcare that could be charitably called clumsy that will no longer have to be clumsy. And that, my kids will not have to have the kind of irritating and frustrating interactions with the healthcare system that maybe those of us my age and older have just learned to endure. So I say bring it on. It's going to be exciting to see what happens. Joe, I'm going to close my remarks there, and I look forward to hearing the presentations of others and conversations.
Perfect. Bring it on, Cris. Absolutely. Thank you so much. Any questions? Isaac's going to go next from the EHR vendor perspective, but any questions specifically for Cris? There's some incredible things that Mayo is able to do from a patient-centered perspective, and any details. John.
I was just checking if we have audio interoperability. Hey, Cris, can you hear me?
I can.
Hey, well, so good to hear from you, and I hope all is well. So two questions for you. So Carolyn Clancy, you'll be happy this morning, told us essentially that technical interoperability without organizational redesign simply gets you a bad result faster. So I think your comments about we need to change process we need to get to that organizational interoperability that Joe referred to are really important. FHIR is just a tool. It is by means, standing alone, not a solution. But here's my question. We went at Beth Israel Deaconess live with patient self-scheduling 2 weeks ago. And so it's live. It works. It's great. And I'm curious what you think, because Mayo is always very forward-thinking. An 85-year-old woman with new chest pain and shortness of breath would like a 2-hour visit 6 weeks from now. And you say, oh, approved, or do you say, humans have to review this? Or similarly, an 18-year-old with an ankle sprain wants a visit tomorrow. How do you deal with the fact, to your point, this is not like getting a table which is effectively equivalent throughout the restaurant?
Well, John, what we're going to do is get on a plane and come to someplace smart like Beth Israel Deaconess, and we're going to shamelessly copy what you did. No. That is exactly the problem that we're confronting, and I would be fascinated to hear what you want to do. We are in the early stages, and so whatever I say here, I'm going to err on the side of candor, and I'll probably get it wrong. I will tell you some things we won't do, as opposed to be real cagey, which doesn't help anybody. So the kinds of things we've been thinking about are, for example, return visits of a non-trivial basis. So I have been a patient at Mayo for a little while here, and it's pretty easy for me to make a request via the portal that I want to come see my clinician because I have a question about X. That goes through a human today. What a waste of time. It's pretty easy to have an algorithm that says, this is an established patient, he's well known, we know what his situation is, we're going to offer that appointment right now. I think the place, John, where we'll begin is to create a standard appointment about the presenting condition that the patient or the patient's physician represents to us. We will have a standard opening visit for the kind of patient that you talked about. We wouldn't offer a treatment option, but we would offer a evaluation and diagnostic option as kind of a first offering. But boy, the devils are in the details, and I would be fascinated to hear how it's gone for you and other leaders in this field.
And so, Joe, what I might offer is, as part of our committee service, Amy Goldman is the person who actually implemented that at Beth Israel Deaconess and put it live over a year of planning. Mm-hmm. We will just contribute her entire corpus of knowledge to your effort.
Thank you so much, John.
And as you know, Chris, I'm an open source guy. It's all yours for free.
Holy mackerel. John, you never cease to amaze.
Thanks, John. Rachel.
Hi, this is Rachel. I'm an independent consultant, but from Healthcare IE. And I have a question, maybe multiple questions, related to the decision tree. And I was wondering if the decision tree actually functions sort of like as a script for schedulers to follow. Are they answering questions and it's narrowing down options? And in what kind of sequence in general does it move? Does it first try to help determine the right provider and then the right time? So just a little bit more like practicality, how the decision tree helps the scheduling workflow.
Yeah, thank you. There's really two different kinds of decision trees. One is exactly as you say, and our Office of Access Management has a whole set of kind of branching logic and scripts that help us when someone calls up and says, I would like to have an appointment at Mayo Clinic. And, the first question is, for what reason? And it is, I'm tired all the time and I have a headache. You got to get a lot more specific than that before you can get to the right place. So they have a whole bunch of intake and routing questions that do that. So that's one form of decision tree. And that kind of decision tree is more or less human navigable, right? You can find your way through that set of scripts and questions. Then there's a second set of decision trees which deals more with the capacity and location of specific kinds of things. So I'll give examples from my own care. I've been pretty open about this. I've been a cancer patient at Mayo for the last 10 months, and I'm emerging at the other end, and all is good. But I had to have a particular surgery that required 2 surgical teams and an interoperational radiation therapy team. I had to have my surgery rescheduled 3 times. Frankly, it got rescheduled because they thought they could move me because I'm one of the gang. I'm on the team. Other patient needs came up. And I was happy to cede to other patients. It really didn't make any difference to me. But this was a place where there literally is a kind of integer programming model, if you're familiar with those kinds of things, which is a huge multivariate problem set that a computer figures out how to come to an optimal resource allocation or routing conclusion that maximizes across a couple of attributes. And the attributes that we're trying to maximize across are completion of patient itinerary on time, and then some measures around physician load. We don't want to completely burn out our physicians, obviously, and so we're careful about that load. So again, there's sort of a set of human-readable decision trees, and then there's a set of kind of algorithmic, computer-readable decision trees that then result in an optimized schedule result.
Excellent. Thank you, Cris. If we can stay on the line, too, I'm sure we'll have more questions as we go along. But just to push us through, can I invite Isaac to come up and share some of his thoughts?